So today's topic is dyspepsia. Dyspepsia or indigestion is a difficult, sometimes vague symptom to define or evaluate and requires very careful questioning to clarify the exact nature of the complaint. It can embrace as nausea, heartburn, regurgitation, upper abdominal discomfort, lower chest discomfort, acidity, epigastric fullness, and bloating. So when dealing with dyspepsia, it can we can have many differential diagnoses. So to aid our diagnosis, we are going to follow our diagnostic model, which starts with probable diagnosis. When a patient comes to you with the complaint of indigestion or dyspepsia in OPD, what can be the probable diagnosis you can think of? It is usually irritable or upper GIT, for example, functional. It can be functional when there is no systemic or structural cause found. Then we have gastroesophageal reflux disease. It is the one of the most common causes of dyspepsia. Some drugs that the patient is taking for different diseases, esophageal motility disorders. Now coming towards serious disorders which should not be missed when the patient is complaining of dyspepsia. These can be neoplasia like cancer of stomach, pancreas, and esophagus, cardiovascular diseases, and if the patient has chest discomfort and upper abdominal discomfort, we can suspect the cardiovascular diseases like ischemic heart disease, congestive cardiac failure. If the patient has upper abdominal discomfort with which is radiating to back, we can suspect pancreatitis. Then we have peptic ulcer disease. Now, what are the pitfalls? Pitfalls are the disorders which often get missed when we are dealing with dyspepsia, chest discomfort. These are a myocardial infarction. When the patient is complaining of chest pain, especially after eating, we can often miss the cause is most of the times myocardial infarction. If the cause is myocardial infarction, we can easily confuse it with indigestion and dyspepsia, and we can misdiagnose it. So MI often get missed. That's why it is a pitfall. Then we have certain food allergies. For example, after milk ingestion, peanut ingestion. Then we have pregnancy. Pregnancy is very common cause of dyspepsia. Hepatobiliary diseases, post-vagotomy, eclasia, duodenitis, autoimmune gastritis, and Zollinger-Ellison syndrome. Now we have seven masquerades. Um, in seven masquerades, depression can be the cause of dyspepsia. If the patient can have functional irritable upper GIT. The patient can have diabetes. If the patient has autonomic neuropathy and gastroparesis, it can lead to dyspepsia. Certain drugs like alcohol, steroids, aspirin, NSAIDs, bisphosphonates. These are very common causes of dyspepsia. Is the patient trying to tell me something? In patient trying to tell me something, the patient can has anxiety or any stress going on in his life, which can lead to dyspepsia. Now coming towards very important part of our video, that is red flags. Red flags are very important, and you should see or search for red flags in every patient who is coming with dyspepsia. Number one, we have abnormal symptoms of reflux or dyspepsia. The symptoms are changing with the span of time, and it is associated with dysphagia. The patient also has anorexia, weight loss, or history of GIT bleeding like melena or hematemesis. The patient is having pain that is radiating to back, and which can signify pancreatitis. Pain that is awakening the patient at night. Pain is so severe, discomfort and pain is so severe that the patient is waking up at night along with dyspepsia, and on examination there are some abnormal signs. There is any abnormal finding on examination. So these are the red flags which can lead us to some serious disorders. Now, some important points to mention which can aid in our diagnosis are if the patient is complaining of localized pain, it is usually said to be of ulcer like pain. And if the patient has diffuse discomfort, it is usually said to be dysmotility like kind of pain. And diffuse discomfort feeling after meals, and it is associated with nausea, bloating. It is usually dysmotility like pain. Acid reflux like pain is associated with indigestion, heartburn from regurgitation. Some associated symptoms with dyspepsia are if the patient is having difficulty swallowing, it can be esophageal disorder. If the patient is complaining of lump or constriction in throat and a real feeling of lump in his throat, he is having dysphagia and dyspepsia. It is usually psychogenic in nature. And if the patient has acid regurgitation, it is usually GERD or esophagitis. If the patient has dyspepsia along with anorexia and weight loss, it is pointing towards gastric carcinoma. If the patient has water bash, feeling of water bash, that is the patient is having mouth full of water with dyspepsia. It is usually associated with gastroesophageal reflux disease, hiatal hernia, peptic ulcer. If the patient has symptoms of anemia along with dyspepsia, it means that the patient is having chronic esophagitis, gastritis, peptic ulcer, or cancer. If the patient also has flatulence, the flatulence is actually the excessive wind in the stomach, in the GIT tract. There's belching, abnormal bowel habits. Um, these can come under IBS and inflammatory bowel syndrome, irritable bowel syndrome. And if the patient is also having diarrhea, which is 30 minutes after the meal, it can be mesenteric ischemia. Now, what are the causes of dyspepsia in the elderly patient? If a patient is elderly and he is having chest discomfort or upper abdominal discomfort and dyspepsia, we can suspect stomach cancers, constipation, especially in bedridden patients, mesenteric artery ischemia, congestive cardiac failure. In children, what are the causes of dyspepsia? These can be gastroesophageal reflux disease, cow protein allergy. Gastroesophageal reflux is usually physiological, especially in newborns, and the patient has and the child has colicky pain. And cow protein allergy can be there. Drugs, certain drugs in children can cause dyspepsia. Dyspepsia in adults, we are going to do it individually. First, we have gastroesophageal reflux disease. It is associated with nausea, bloating, belching, and water bash. Nocturnal cough is there. The patient is complaining of these symptoms, especially at night when he is lying down, and there's hard regurgitation, and due to which the patient is complaining of heartburn. So these are some of the symptoms of gastroesophageal reflux disease. So what are the red flags which can point towards endoscopy, for which we have to do endoscopy? Some of the red flags which are associated with gastroesophageal reflux disease, and we have to diagnose it through endoscopy. These are anemia. If the patient has GERD and he has a new onset anemia, patient also has dysphagia or odynophagia. The patient is complaining of hematemesis or melena. There is unexplained weight loss of more than 10%. There is vomiting, older age of more than 50 years, and chronic NSAID usage, severe frequent symptoms. There are frequent symptoms which are severe, and there is a family history of cancer, short history of symptoms, unresponsive H. pylori treatment, Barrett esophagus screening is required. If a patient is high risk and he needs Barrett esophagus screening, he is also a candidate for endoscopy. Now coming towards hiatal hernia. Hiatal hernia is usually in obese patients of more than 50 years of age, and it is mostly asymptomatic, but GERD is common, right? We have two kinds of hiatal hernia. If the patient has sliding hiatal hernia, the gastroesophageal junction slides into the chest, and in that condition, acid reflux is common. In rolling hiatal hernia, there is a bulging stomach herniates into the chest, and if the stomach herniates into the chest, it is prone to strangulate. So rolling hiatal hernia is prone to strangulation, while sliding hiatal hernia has a complaint of acid reflux. Functional and non-ulcerative dyspepsia. If the patient is complaining of ulcer-like pain, if the patient is having ulcer-like, which is localized pain, we will treat it as GERD. And if the patient has dysmotility-like, which I explained previously as a diffuse kind of discomfort, we will going to treat it as emotional stress and poor diet. Now we have Barrett esophagus. Barrett esophagus is actually the metasplastic response to prolonged reflux, and it is a pre-malignant condition. And the screening is required 2 yearly endoscopy. Screening is required 2 yearly by endoscopy. Then we have stomach cancer. Stomach cancer, the risk factors for stomach cancer are increased age, blood group A, smoking, sugar, increased sugar intake, atrophic gastritis. The patient has a history of H. pylori, and a special sign which can point towards this examination point, which can point towards the stomach cancer. If the supraclavicular lymph nodes are enlarged, it is called as virtue stride, and it is a Trossier sign which signifies the stomach cancer. Now we have autoimmune gastritis. Autoimmune gastritis. In autoimmune gastritis, there are antibodies to parietal cells and intrinsic factor, which can lead to pernicious anemia because intrinsic factor is responsible for the absorption of B12. So we are going to treat autoimmune gastritis with iron and B12 supplements. So and a very important heading, that is when we are going to refer the patient to specialist. When the patient is an infant with persistent reflux, the patient is failing to respond to stage one of heartburn and endoscopy, stage one of heartburn treatment, that is dietary modification and healthy lifestyle, and the endoscopy is required. We are going to refer the patient to a specialist. There are persistent and recurrent ulcers, and there is the peptic ulcer complication like hemorrhage or bleeding. That's it for dyspepsia. Thank you.